Good morning. I'm Giuseppe Citerio from Monza, Italy. And in the next 12 minutes, we will discuss about head trauma, recent development. I have no conflict of interest for this presentation. So the agenda of this presentation will touch some point. We will start discussing about the new population, the traumatic population that is old and fragile. We will discuss a little bit about extracranial complication and the variation of treatment we apply in the intensive care unit across Europe. And I think we will finish thinking about the future and try to understand how to improve our knowledge of this topic. Talking about the population, if we look at the incidence of traumatic brain injury, severe traumatic brain injury, the B part of this panel, we could see that we have a peak in the middle age, around 20, and this is predominantly male incidence, but we can see that the major part of the trauma is in the right part of this graph, so in older patients, higher than 70. And as you can see, the incidence on higher age is quite impressive. And if you think about my clinical history, when I started working, I was used to have a young trauma, previously health, involved in a high-speed trauma with a lot of extracranial lesion, including bleeding, and with a lesion like a diffuse axonal injury, like in the MRI in this slide. And in the right part is the new population we are facing elderly, usually traumatized by fall, with a lot of comorbidities, no extracranial lesion, and as you can see, the most important lesion is the subdural hematoma that has a lot of mortality. We try to collect a lot of information in Europe using a network, a so-called Center TBI network, and the two presentations in this session will touch this data set that enroll 4,500 patients in the core data set and 22,000 patients in the registry. 2,000 of them, more than 2,000 of them were in the ICU. And if we look at the mean age in the center TBI population, the mean age is around 50, and a quarter of patients admitted to our unit is higher than 65 years. And the most important cause of trauma, as you can see in pink here, is incidental fall, mainly in the low and high, extremely low and high age range. If you think about the intensive care, we were thinking that only comatose patients are assessed to ICU, and what we discovered, we were a little bit surprised with center TBI that also less severe patients did enter in the intensive care unit, and Nino Stocchetti in the next presentation will touch this point. And looking at the outcome didn't change so much in the last 20 years, with a mortality in the overall population admitted to ICU around 18, and a negative, a severe outcome around 44% at 6 months. We started to develop in the Center TBI collaboration also. We tried to build a frailty index in TBI using the Rockwood approach that is the cumulation of deficit. We use more than 30 potential deficit and pathology. And what we saw in 750 patients in the ICU, that the cumulation of deficit goes up with age, and the more frail patients are, as we can expect, the older patient. But as you can see, looking at the frailty scale, frailty, a severe frailty, higher than 7, start around 60, and all the severe patient, frail patients are old, and this frailty has an impact on outcome. We didn't explore so much in the past the effect of frailty or comorbidity, and I think is a topic we need to address in the future. And so this fragile population enter in our unit. Most of them have an older age, we said, and extracranial complications are a frequent problem after the admission in the unit. And we have a cardiac problem, GI problem, liver failure. But we focus in this presentation on VIP, ventilation-associated pneumonia, and acute kidney injury. Thinking about acute kidney injury, a lot of meta-analysis try to address this topic, and with a different number of incidents of acute kidney injury. We enroll 102,000 patients in which we have the data of urine output for days and creatinine and urea for days. And we calculate the incidence of acute kidney injury that is around 12%, with 3% of severe cases. As you can see in the right part of this graph, the red part is the acute kidney injury development. As you can see, over time in the days, we have an early start of acute kidney injury with a median of 2 days after the admission. So it's a very early phenomenon. And we were surprised to see that this incidence is very variable across country. And as you can see, for our country, and the green is no acute kidney injury, the red is acute kidney injury. As you can see, there is a striking difference between countries. We were surprised about that, and Center TBI allows us to explore this difference between center and countries, and we will see in other settings later on. And we were starting to look at the factor that influence the development of acute kidney injury. As you can see, the renal history is a factor we cannot change. Diabetes is a factor we cannot change, but we were surprised of the association with osmotic therapy administration and increased sodium, higher than 150 milliequivalent milliliters. So as you can see, there is something we can change in our treatment. So the use of the osmotic therapy and the upper limit of sodium that are linked with acute kidney injury. We say that it's not so frequent, but when the patient experiences acute kidney injury, there is an impact on mortality, as you can see in the Kaplan-Meier curve, and also in an increase in a worst neurological outcome like 6 months. So as you can see, that is a not so frequent problem, but when it happens, has an impact on outcome, and we have some factor we can change, for example, the upper limit of sodium. Almost all the severe patients are ventilated in our unit after TBI, and we did explore the frequency of ventilator-associated pneumonia, and you can see VIP is present in 20% of the population. And looking at the time frame of the development of the complication, you can see that is a little bit later phenomenon. The median interval is around 5 days, and with a peak around 7-8 days. And the patients that develop VIP were younger, with more frequent thoracic trauma, and with higher probability of inhalation after trauma, with alcohol abuse and drug abuse before trauma. And they did experience some episode more frequently of respiratory failure during the ICU stay. Looking at the ratio between PR2 and VO2 and the day in which VIP has been developed, you can see there is a trend of reduction of the ratio between PO2 and VO2 starting days before the development of VIP, and this effect remains even if it's not so severe also after the development of VIP. Looking at the difference between countries, as you can see also in this slide, also for VIP, that seems a very common complication. We have difference between country with a very low incidence and with country with very high incidence. And looking at the factor that could influence the development of VIP, age could not be changed, so older patient, chest trauma, but the 2 factors could be changed during the ICU stay: the use of H2 receptor antagonist and the antibiotic prophylaxis. The first one, the H2 receptor antagonist, increase the probability of having VIP. But on the other hand, antibiotic prophylaxis, that is strongly discussed in this setting, is associated with a reduction of risk of VIP. So we have factors we can influence for increasing or reducing the incidence of VIP. And the patient with VIP have a longer duration of mechanical ventilation, but there is no any impact on outcome. And we already see some variation in treatment. I will focus on 2 points, intubation and tracheostomy, in the next few minutes. And as you can see in this slide, Center TBI offers us the possibility to compare different systems. There is a difference in response time. The slides represent the difference between the countries, and the yellow color is the mean value, the red color is an higher value, the blue color is a lower value. As you can see, there are different in the response time, on-scene time. We have France, for example, with a long on-scene time. The two models stand, scoop, and play, and remain on the place are seen in this slide. But also we have, for example, for UK, very long travel time, because the number of trauma center is very low compared to other countries in UK, because the patients are centralized. But also for IV fluid, there is a striking difference between countries. With UK with very low amount of fluid, and Germany with a very high amount of fluid in the extra hospital phase. And if we look at the intubation, difference in intubation, you can see the pre-hospital phase on the left part of this slide. France and Italy, they have a very high incidence of pre-hospital intubation, and the other country have a lower incidence of pre-hospital intubation. And having a pre-hospital care team with an anesthesiologist on board increase the probability of having intubation outside the hospital, but also having a more severe trauma, and reactive pupil, and face and thorax chest, head and neck trauma increase the probability of having an intubation. We focus also on tracheostomy because it's a procedure that we do frequently in our unit. And as you can see, there are striking difference in the performance on tracheostomy. In red is late tracheostomy, in green is early tracheostomy. And you can see a difference between countries on this topic. And we discover that late tracheostomy are associated with a worse outcome compared to early tracheostomy. And also on these points, we can change our behaviors, thinking about having an earlier tracheostomy compared to the past. Going to the conclusion, gathering this large amount of information helps us in understanding the difference between treatment and countries, and we have a better possibility of targeting our treatment. And going to the last line, we are facing a new population of TBI with high heterogeneity in treatments, and I think we need to put our mind on the factor we can avoid for improving outcome in this TBI population. Thank you very much for your attention.